Hello there, everyone. Good morning, good afternoon, good evening, whatever time it is on your end that you've chosen to tune in. I want to take this opportunity to welcome you to today's lesson, in which we shall be discussing prevention of HIV infection in children. Now, this lesson is primarily designed for clinical medicine pediatric students, and so I want to encourage you to share it around with fellow students, colleagues, your friends for purposes of just building their knowledge or just for revision. I hope you find the content of this lesson useful and beneficial. And so I want to invite you to give this video a thumbs up. Yeah, when you give it a thumbs up, it means that you like it. I also want to invite you to subscribe to the channel. That way, when we post another video whose topic is of interest to you or whose topic may resonate with you, then you'll be able to know in good time. My name is Violet Aswa, and it's my pleasure to be here. And I also want to appreciate your presence and thank you very much for choosing to tune in today. Now, this lesson is fairly broad, and so it has been divided into three parts. The first part, we shall be looking at prevention of mother-to-child transmission of HIV infection. In the second part, we shall be looking at horizontal transmission of HIV in children and how to prevent it. And then we shall be looking at prevention of HIV transmission in healthcare settings, that is in part 3. So we delved straight away into part 1, where we shall be looking at mother-to-child transmission of HIV and how to prevent it. Now, before we delve into the details and the nitty-gritties of this topic, I would like us to look at the burden of this disease, and so we'll be looking at the magnitude of HIV in children and also look at the magnitude of mother-to-child transmission. And we shall be looking at this generally and then also looking at the picture in our own country, Kenya. Now, it's important to remember that HIV transmission can occur from any infected mother to their baby or unborn baby, either during pregnancy, during labor and delivery, or after delivery during breastfeeding. Now, this sort of perinatal transmission of HIV directly from mother to child is what is referred to as vertical transmission. Now, I want you to look at these numbers. Mother-to-child transmission of HIV accounts for over 90% of pediatric HIV transmission. Now, also, of all the cases of pediatric HIV in the world, over 90% of these cases are found in sub-Saharan Africa, where we happen to be situated. And then, Kenya is among the 22 countries which collectively account for over 90% of all pregnant women living with HIV. So this epidemiologically really places up in what may be referred to as maybe epidemiologic hotspots. And so our country is precariously placed, and so this is a topic and a problem that we must pay attention to and take action against. According to the UNAIDS report of 2020, it was estimated that in 2019, 38 million people were living with HIV globally, and of that number, 2.8 million were children. Now, in the same year, about 880 children got infected every day, and a further 310 children died on a daily basis from AIDS-related causes. Now, that's a rough estimate or translation of about more than 320,000 infections daily and more than 100,000 deaths every day. And these were mainly because of inadequate access to services. And here we are talking about preventive services and care and treatment services. Similarly, when you look at the infant mortality rate at that time, 1.5% of those deaths were caused by AIDS and its related causes. And beyond the infancy period, when you look at the age group between 1 and 4 to 5, thereabout, another 4.9% mortality of those children is accounted for by HIV and AIDS. And so you can see this is a problem that is affecting the whole world and in a major way. Now, what is the Kenyan situation? Kenya alone accounts for 4% of all new pediatric HIV infections globally, and also 7% of all childhood deaths occurring because of HIV and AIDS. And every year, it is estimated that 13,000 new infections among children occur in Kenya. So clearly you can see that, without belaboring the point, that this is a problem that is with us. It is of high magnitude, and we need to pay attention to it and do the necessary actions. So let us shift our focus slightly to women. And it has been estimated that every year, 1.3 million women who are already HIV infected become pregnant. Now, you see, if nothing is done, then again, here we are looking at a huge population of children who are at risk of getting infected perinatally. Now, it has been estimated that up to 30% of infants are at risk of acquiring HIV gestationally and during delivery, and a further up to 15% risk is posed during breastfeeding. So this gives us a total of about 45% perinatal risk of HIV transmission from mother to child. Now, when you look at these percentages, 45 is not very far from 50%, which means then close to 50% or half the population of children born to HIV infected mothers are likely to be HIV infected. And already we have seen that the number of HIV infected women who become pregnant every year is also very high. So again, this is just at the risk of sounding like we're belaboring the point, but we are saying that these numbers are high, and therefore this is a situation that we must pay attention to critically. Now, when HIV occurs in infants and young children, then this tends to increase the mortality of children. We've already seen that the infant mortality rate due to HIV alone is 1.5%, and up to 5 years, between 1 and 5 years or 4 years, is about 5%. You see, that is very high. So we are looking at increased mortality. We are looking at chronic disease, children being exposed to a chronic disease, which means then the life expectancy is also shortened, and also it is very expensive, Now, with time, there's been a shift to try and totally eliminate the transmission of HIV from mothers to their unborn children or to their born children. And these interventions are pretty simple, and they're highly effective. And the basis is really just putting the mother on lifelong ART. And when that happens, then it becomes virtually possible to totally eliminate HIV from infecting children. And that is very good news, and we should actually capitalize on that. But this can only happen if we are able to identify mothers and be able to link them to care and treatment, and also offer partner support services. You see, when a mother comes in and they're pregnant and we do the testing and we find that they are infected, then that again can become an entry point to try and reach out to the partner so that both can be linked to care and treatment. And so identifying these women is very, very key so that this can happen. Now, in the same year of 2019, by 2019 actually, up to 85% of women and young girls globally were able to access ART in order to prevent mother-to-child transmission of HIV. However, while 85% is fairly high, and that is the enrollment of women and girls into care, the same does not seem to reflect when you look at the transmission of HIV from mother to child. And so this begs a question of how are we able to retain these mothers into care? So we have high numbers being recruited into care. They have been identified, or 85% of those are recruited into care. But then when you look at the outcomes at the end of delivery and children, then you don't find a similar reflection. And so we must prioritize certain things. Number one is to prioritize retention of these women into care, because that is the only way we can be able to protect the children from getting infected. And also we must be emphasizing and putting in measures that ensure that mothers who are not infected and young girls who are not infected, generally the population that is not infected does not get infected with HIV. Okay. So now, having looked at the magnitude of HIV in children and the magnitude of mother-to-child transmission, we've spoken a little bit on prevention and its importance. Let us now look at what has been the impact of PMTCT. Now, we are going to look at the trends from as far as the year 2000 up to the year 2021, depending on the data that is available to us, and you shall see the importance and what has really happened because of that. So it is recorded that in the year 2021, 160,000 new HIV infections occurred among children under the age of 5. And this was a decline from an average of 320 in 2010, which was about 50%, a 50% decline. Now, in the year 2011, the global plan towards the elimination of new HIV infections among children and keeping their mothers alive was introduced. And since then, there has been dramatic progress in reducing mother-to-child transmission of HIV. This has largely been due to increased access to PMTCT services and also increased number of pregnant women living with HIV being initiated on lifelong antiretroviral medicines. However, this is still deficient of the 2020 targets that were set by the UNAIDS and partners as part of the Super Fast Track framework, which was intended to end AIDS by the year 2020. And therefore, there is need for acceleration of treatment in order to achieve elimination of new infections among children and also to reduce HIV-related deaths. And so, it's also estimated that since the start of the PMTCT program, 1.5 million deaths and 2.9 million HIV infections have been averted in pregnant women and in children. And from the year 2000 and so between 2000 and 2021, 2.8 million children born of HIV infected mothers were prevented from mother to child transmission of HIV as a result of the implementation and the acceleration of the PMTCT program. And so it is estimated that without the implementation of the PMTCT program globally, new child HIV infections would have been nearly 2.5 times higher than what we are currently observing. It would be important to note that 4 in 5 pediatric HIV infections occurred in sub-Saharan Africa in 2021. It is therefore crucial that pregnant women in this region know their HIV status. And I need not remind us that this region being mentioned here, sub-Saharan Africa, is where we are situated. A couple of key questions beg to be understood if we are to succeed in the endeavor to prevent and eliminate mother-to-child transmission of HIV. This includes the magnitude of transmission, which we've already alluded to, the timing of infection. When do these children get infected? We've already seen the possibility of infection during pregnancy, during labor and delivery, and during breastfeeding. We also need to consider what are the core factors for mother-to-child transmission of HIV, and therefore what strategies can be made available for its prevention. We have already alluded to some of those, and then we shall look at others. Now, let us look at the risk factors for mother-to-child transmission of HIV, and we shall look at this in terms of the risk factors during pregnancy. We shall look at the risk factors during labor and delivery. We shall look at the risk factors during breastfeeding, and then we shall also look at the risk factors associated with the infant themselves. So during pregnancy, several risk factors are observed which tend to increase the risk of transmission. we have the high viral load, and several instances or situations will usually lead to this state. Remember, a high viral load is directly proportional to high risk of transmission of HIV from mother to child. And so what are the situations where we find this kind of thing, high viral load? One is the new infections. Every time there is a new infection, particularly during the window period, there will invariably be a high viral load, because then the immune system has not set in yet to try and control the replication. So new infections during pregnancy, new infections around the time of conception will be associated with a high transmission rate during pregnancy. The other time when you expect a high viral load during pregnancy or any other time is when the disease is well advanced. So mothers with advanced HIV disease and mothers with a rapidly progressive disease. These kinds of mothers will tend to have a high viral load, which is directly proportional to increased risk. Mothers with a low CD4 count, again, this is directly proportional to or directly associated with advancement of the disease. Nutritional deficiencies also, here we are talking about vitamin A and anemia especially. So it's been observed, particularly in sub-Saharan Africa, that pregnant women who are also HIV infected and also deficient of deficient of vitamin A tended to transmit the virus more to their unborn babies. And this has been thought to be due to loss of mucosal integrity, which is usually maintained by the presence of vitamin A. However, we know that conventionally we do not give vitamin A supplementation in pregnancy, and therefore still there has been no evidence of any additional value of giving vitamin A supplementation. Nonetheless, it is not part of the conventional treatments that we do or supplementations that we do during pregnancy. But it's good to know that vitamin A deficiency is directly associated with increasing risk or increased risk of mother-to-child transmission of HIV during pregnancy. Anemia is another factor, and again, it has been observed that pregnant women who also have anemia tend also to have more advanced stages of the HIV disease. Again, we have already seen that advanced stages of the disease will be associated with high viral loads, and therefore that will pose a higher risk of transmission as compared to other women who are pregnant and HIV infected, but they're not anemic. Placental inflammation, this is anything that will upset the placenta and lead to inflammation. And what happens is that when the placenta is inflamed, there will be a disruption of the placental barrier. And so when that happens by itself, as a factor by itself, that will increase the passage of the virus to the fetus. At the same time, the state of inflammation is associated with increased viral replication and consequently high viral load in the placenta, and that tends to also increase the risk of transmission. At the same time, you find that when the placenta is inflamed, it will interfere with the functionality of the placenta itself. And so when that functionality is interfered with, part of what is interfered with is the ability of the placenta to filter off pathogens from transmitting to the infant, and so rather the fetus. And so that is the reason why you'll have a high risk of mother-to-child transmission when there is inflammation of the placenta. We also have the presence of sexually transmitted infections. Now, STIs usually create a state of inflammation and immune activation in the genital tract. Actually, STIs are associated with increased vaginal shedding of the virus, which then dramatically increases the amount of virus in the fetus that the fetus is exposed to. So it's been documented and known that STIs increase the viral load in the mother's genital tract independent of her blood viral load. C. The local inflammation is usually associated with increased immune cells, that is the CD4 T cells, and also increased presence of macrophages. Now, these are the very cells that the HIV virus tends to infect, and the virus also replicates in these cells. And so, a higher concentration of these target cells in the genital tract will usually create a local, quote-unquote, factory for the HIV production at the vaginal, environment. And this intensely increases the concentration of the virus in the vagina and cervical secretions. And this virus can easily ascend to cause a fetal infection. The inflammation that is also caused by the STIs tends to also compromise the placental barrier. And we also have other STIs that are associated with the break in the mucosa, infections like herpes simplex, infections like syphilis will usually cause or be associated with open sores. This then provides a direct portal of entry for the HIV virus, both for sexual transmission to, to a partner, and also it will also significantly increase the risk of mother to child transmission of the virus, because then it will just pass from the mother's genital tract directly to the baby during delivery, especially when the delivery is vaginal. Now, STIs do not only have their effects at the genital level, we also have systemic effects, and so a mother who has STIs will also have a systemic immune activation. So the effects of an STI, you can see they are not just local. So when the system, the rest of the system is immunologically activated, this will also increase the overall viral load. Remember, the state of inflammation tends to increase viral replication in the CD4 T cell counts and macrophages and other white blood cells that are affected. So this widespread immune activation that is caused by STIs can stimulate this viral replication throughout the body, and therefore leading to a total high viral load in the mother. And we know that a higher blood viral load increases the risk of transmission across the placenta during pregnancy. We've already seen that in the previous slide. And when this is combined with the higher genital viral load that we have already seen initially, then the baby is at a double risk from both exposures. Besides the STIs, we also have the high risk sexual behaviors. Now, high risk sexual behavior is at the core of increased viral load, because high risk sexual behaviors can cause a woman's viral load to spike, and this will, even if they are on ART, this can actually jeopardize the protective effects of the ARVs. Okay, and what can happen because of high risk sexual behavior is that a mother can acquire a new HIV strain, and this is just a reinfection or superinfection because of the high risk sexual behavior. And these new virus strains may not be sensitive to the current regimes that the mother may be already on for ART. And then, of course, high-risk sexual behavior is associated with acquisition of STIs, and so we've already seen the effect of STIs. And then also, this kind of behavior tends to interfere with ART's adherence, because the lifestyles that are associated with high-risk sexual behavior is also associated with other social risks that these patients are usually exposed to, or they are involved in, and this poses a structural challenge. For example, these mothers may be involved in substance abuse. They may be involved with intimate partner violence. They may be under situations of poverty, and some of them may even have mental health issues. Okay, so these challenges can directly interfere with a woman's ability to even consistently take their daily ART medication, and that again directly affects the suppression of the virus that we expect to see when a patient is on ART. So poor adherence will usually lead to this, and of course, it is a main and primary driver of high mother-to-child transmission of HIV infection. Now, let us look at the risk factors of this transmission during labor and delivery. Okay, so now we have high maternal viral load. Again, we have already spoken to that, so we shall not repeat. STIs, again, we've already spoken to the genital shedding, the increased genital shedding of the virus, and how the presence of STIs will therefore increase the viral load in the vaginal, in the birth canal, and of course the mother is more, the baby is more predisposed. And then let's now talk about mode of delivery. And here we are looking at the vaginal versus delivery versus the cesarean section. Now, when it comes to HIV and AIDS, vaginal delivery is considered a high-risk mode of delivery because the infant is in direct contact with the HIV-infected cervical and vaginal secretions, as well as maternal blood, and this happens for several hours before they are born, and so this increases the time of exposure that this fetus is exposed to, and therefore increasing their risk of acquiring the infection, you know. Now, there's also what is called the maternal fetal microtransfusions. This happens during labor and delivery, especially during the physical stress that is conferred on the uterus during the uterine contractions. You see there'll be micro cuts in the uterine wall and the birth canal, and so you find there's some mixing of blood from the mother to the fetal blood, and so this is what is referred to as the maternal fetal microtransfusions. And again, this is likely to happen and pose a risk to a baby who is being born vaginally. And then, of course, we have the mucosal exposures, and here we are talking about the infant's exposure. That is the mucus of the infant, the mucosal surfaces of the infant being exposed to this kind of environment that is potentially full of the HIV virus. Remember, the mucosa of the infant are usually very fragile. Here we are talking about the mouth, we are talking about the mucosal linings of the eyes, and very minor skin abrasions can occur during delivery, and that again provides a direct portal of entry for the virus. Now, the other risk factor associated with this kind of transmission during labor is rupture of the amniotic membranes, particularly when it happens more than 4 hours before delivery happens. So usually the amniotic sac and fluid tend to act as a protective buffer between the baby and the mother, and the mother's, secretions from the cervix, secretions from the vagina. So once the sac ruptures, this barrier is naturally lost, and so it tends to increase the direct viral exposure to the fetus, especially during the time when the uterus is contracting. At the same time, we also have increased risk of ascending infection, especially just like we usually consider early rupture of membranes in the case of neonatal sepsis. Again, in this case, early rupture of membranes more than 4 hours before the baby is delivered is also associated with ascending infection, and therefore again that is obviously a risk. Okay, and then we have also the microtransfusions, which occur more easily after the rupture of membranes. Now, still on labor and delivery, we have some instances where one may undergo invasive procedures during delivery. Again, any procedure that causes a break in the infant's skin or the mucous membrane, or any procedure that or increases the mixing of maternal and fetal blood will usually provide a direct portal of entry for the HIV virus present in the maternal blood, and therefore as well as the cervical and vaginal secretions. And so what are some of these invasive procedures during delivery? If you are to do artificial rupture of membranes, if you are to use fetal scalp electrodes for fetal heart rate monitoring, if you are to do fetal blood sampling, if you are to do, instrumental vaginal delivery like the forceps or vacuum extraction, or if you are to give an episiotomy, all these things are invasive in nature. They tend to present open portals of entry for the virus and mixing of maternal and fetal blood. And so as much as possible, these procedures are to be avoided, especially when it is known that this mother is HIV infected and they are undergoing labor and they're about to deliver. Then we also have the firstborn versus the second twin, that is in terms of twins. So you find that the second twin is at higher risk because they tend to be exposed to the cervical and uterine secretions for a longer duration than the first twin. So that is just something to consider when you're dealing with multiple pregnancies and they have to undergo a vaginal delivery. Now we are looking at the risk factors of transmission during breastfeeding. Again, here we have quite a couple of them. So here we are referring to the duration of breastfeeding as well as exclusive versus mixed feeding. So that means that where the risk is involved, the longer the baby is breastfed, the higher the risk of the more they are exposed, and therefore the higher the risk of transmission. And mixed feeding has for the longest time been associated with increased risk of transmission. So remember previously we used to say that either a mother exclusively breastfeeds or they don't breastfeed at all and they do formula feeding. But you remember they are fast. But as we shall see, at this time when the interventions are done well and correctly, and remember they are simple, they are inexpensive, then a baby should be able to be exclusively breastfed throughout the 6 months and even up to 2 years after weaning has been done. So that is about breastfeeding. Then we have maternal disease status. Of course, mothers who have advanced HIV disease are likely to transmit the virus to their babies during breastfeeding because advanced disease is associated with increased or a high viral load. And then we talk about the breast tissue itself. When they have breast disease, mothers with breast disease are likely to transmit the virus more readily to their infants than those without. And which are some of these diseases? We're talking about mastitis, whether it is clinical or subclinical, it is still, remember, it is a state of inflammation, and we have already alluded to what inflammation really does and how it ends up increasing the viral load in the body. And then of course cracked nipples, again these are direct exit points of the virus and the baby will just be taking them directly. And of course we have breast abscess, which is an extension of mastitis. Like I said, when we started looking at the risk factors, we were going to look at what are the risk factors of transmission but associated with the infant. So here there aren't so many. So here we are talking about prematurity and low birth weight, and then we look at, portals of entry on the surface of the baby, that is the mucous membranes and on the skin. Now, looking at prematurity and low birth weight, it's been found that prematurity and low birth weight are like invariably associated with an immature immune system, and this is usually due to low T cell counts. And also, besides the count being low, the functionality is also immature, and therefore this makes it easy for the virus to cause infection. And usually, naturally, these babies will have a weak and more permeable mucous membranes, again, especially in the GIT and the respiratory tract, and therefore this makes it again easy for the virus to pass through and cause infection. Now, prematurity and low birth weight deliveries are also associated with the compromised placental environment, which again creates more opportunities for the virus to pass from the mother to the infant, and therefore making the infant more vulnerable to this infection. So, and particularly when these pregnancies and births are associated with chorioamnionitis, or there is prolonged rupture of membranes, okay? And then preterms also and low birth weight babies also tend to have an immature blood-brain barrier, which we commonly refer to as the BBB. And so this BBB in the preterms is not fully formed or developed, and therefore the HIV virus can easily cross this barrier, and it tends to form a direct direct entry to the central nervous system, and when there, then that forms a sort of reservoir that is usually very difficult to treat and for the drugs to reach. So this is a critical risk factor. And of course, when in prematurity, we also have a high maternal-fetal microtransfusions, like we've already explained. The other thing besides prematurity and low birth weight is a break in the skin, breaks in the mucosal membranes, especially if there are sores in the mouth, if there are oral sores, oral thrush. Those again pose a direct risk factor, but in the direction of the infants. So having looked at that, then what are the consequences of infection in the mother, that is the HIV infection in the mother? Several things happen when the mother is infected. Number one, there's the risk of mother-to-child transmission of the virus. Then, of course, the disease can kill the mother. You know, the consequences of the disease. The mother can die. When the mother dies, the father is likely also to die, maybe, depending on whether they're infected and to what extent. And then here we are having orphans. And you know, when a mother dies, it's been documented that when a mother dies, the baby has a 5-fold increase of dying or risk of dying when the mother dies than when the mother is alive. So of course we have increased child deaths over and above the fact that the disease itself also increases infant mortality and child mortality. And then when mothers die, of course we have loss of critical family and community manpower and resources, and here we are talking of the parents. And of course when mothers die, most of the time we have dissolution of families. And you know, most of the time mothers tend to be the center and the glue of many families, and so when they die, this is lost and a lot of things go wrong. Therefore, what can we do? We need to prevent, if not eliminate, but you see the direction right now is towards elimination, because remember we said with the strategy of lifelong ART, we can virtually eliminate the transmission of HIV from mothers to children. And so mother-to-child transmission, we can prevent or eliminate it through the following strategies. We have primary prevention of HIV, and then we have, so here we are looking, and we shall look at the details. We want to prevent the occurrence, the incidence of HIV completely from the, you know, women of childbearing age, and you know, the entire population that is not infected. We want to make sure that it is not infected, because remember, this is mainly sexually transmitted most of the time, especially in heterosexual settings. And so we are talking about both men and women, okay? As much as we are referring to women mostly because they're the ones carrying the babies, but remember we also have the men. And then we want to prevent unintended pregnancies, you know, Mothers should not, especially those who are infected, should not just get pregnant anyhowly. They should plan their pregnancies through the strategies like preconception care. And then effective access to HIV counseling and testing. Remember, we said one cannot be enrolled into care unless we know the HIV status, and you cannot know the HIV status of a mother if they are not tested, And then initiation of lifelong ART with support for adherence. Remember, adherence is very important. Retention and into care, and viral suppression for mothers who are already living with HIV. Viral suppression is the key, and that is the goal and the target of all this. And then we want to ensure and practice safe delivery practices, and then ensure optimal infant feeding practices. Here we are talking about exclusive breastfeeding and access to postnatal ART prophylaxis for infants. So you can see we prevent infection entirely, prevent unintended pregnancies, testing, availed counseling and testing, initiation of lifelong ART for the mother, provision of infant prophylaxis, safe delivery practices, and infant feeding. I think infant feeding is covered under primary health care in pediatric HIV. So what then do we do? In the year 2012, Kenya launched a plan for elimination of mother-to-child transmission of HIV, which involved the joint United Nations Program on HIV and AIDS, that is the UNAIDS 4-pronged strategy. And it stated as follows. Number one, the first prong or strategy is primary prevention of HIV among women of childbearing age. Prong number 2 was prevention of unintended pregnancies among women who are living with HIV. And prong number 3, there is prevention of HIV transmission from mothers living with HIV to their infants. And prong number 4 is provision of appropriate treatment, care, and support to women living with this disease and their children as well as their families. So number 1 is prevention of HIV entirely. Number 2 is to prevent unintended pregnancy in those who have already been infected. Number 3, when they get pregnant, we want to prevent transmission of that virus to their babies. And if the transmission occurs, then we want to make sure that they are receiving appropriate treatment, they are receiving appropriate care and support, both the mothers and the infants. And not just that, but the entire family. Now, for these goals to be realized, like I've kept on saying, it's impossible to be enrolled into care and get treatment and support without knowing the status. So screening and treatment are very key. So here we are targeting that more than 90% of HIV infected women should be identified. We want to reach as many as possible, So the target is more than 90% of HIV infected women should be identified. And this can only happen through screening. So we do that by offering the test during the routine antenatal visits. Okay. Now, once we have identified them, then we need to enroll them into care and make sure that they are retained into care. Okay, that is the only way we can effectively achieve elimination of transmission of this virus to the baby. Remember, without treatment, there is up to 5% risk of babies born to these mothers are getting HIV infected. But if the mothers are aware of the HIV status, if they are infected, they are enrolled into treatment and they are adherent to the treatment, they receive adequate support, the babies are getting, what do we call this? The babies are getting prophylaxis, then other than just getting up to less than 2% risk, we are able to totally eliminate the transmission of this virus from infecting children. Now, that is about screening and treatment, ensuring mothers are screened adequately, ensuring that those who are infected are enrolled into care, and it is appropriate care, treatment with adherence. Then We also have integration of the EMTCT services into the regular MCH services, into the regular newborn services, and into the regular child and adolescent health services. That way, we are able to get them as early as possible. Even the children where the mother may not have been tested and therefore caught, and maybe for some reason then the child got infected, then we are able to get them even during the neonatal period, even during the early childhood period, and even during the adolescent period when the services are well integrated. And then we need to further promote access to appropriate sexual and reproductive health services to all our women and young men, and then prevention of unintended pregnancies, and also screening and treatment for STIs in women and girls who are already living with HIV. And I think we've already alluded to the importance or the role STIs play in terms of viral loads and all that, and availability of the virus, and therefore exposing the baby to higher risk. And so it is very important that we screen these women for any possibility of STIs, and they also get appropriate treatment. So this is what we are talking about. Now, going forward, the government of Kenya and through the Ministry of Health, UNAIDS, and other partners has now introduced what we call the Triple Elimination Initiative. The Triple Elimination Initiative is actually referring to, prevention and elimination of transmission of not just the HIV virus, but also the hepatitis B virus and syphilis. Okay. So now this initiative aims at promoting person-centered care. It aims at reducing the incidence, mobility, and mortality due to these infections, and strengthen disease monitoring through the use of strategic information for response planning. So prevention of mother-to-child transmission or elimination of mother-to-child transmission of HIV, syphilis, and hepatitis is what we are talking about. And these tests should be offered as part of the antenatal care package. And usually it is an opt-out sort of situation. Remember, with HIV, you must obtain consent. Previously, we've always done the VDRL screening. We've not traditionally just been doing for hepatitis B, but now with this initiative, then we do the triple screening. Now, all pregnant women, unless non-positive, should be cancelled and tested for HIV, syphilis, and this is good enough. There is a dual kit which is able to pick both syphilis and HIV, very sensitive, and then the hepatitis B virus during their first antenatal care visit. If any of these tests is negative, then it should be repeated. The test or tests should be repeated in the third trimester. If they are positive, then the mothers should be initiated on appropriate treatment as soon as possible, actually, if not immediately. So we made reference to the 4 prongs, and so let's look at each of them. The first one was primary prevention of HIV. So we want to make sure that the uninfected populations remain so. Okay, and so who are we targeting here? We are targeting both women and men who are already sexually active. And so we usually say that abstinence is the most effective and sure way of keeping away HIV. Of course, the one that is transmitted sexually. It's the most effective, really. But we know that we may not always achieve that, and like we rightfully say, that we are targeting men and women who are sexually active. So if men and women are not able to abstain, then they should be faithful to one partner. And this is a personal considered opinion. I consider faithfulness to only work if you are referring to married couples. Otherwise, if you're referring to people who are just in casual relationships or relationships that are not binding, then I think condoms should just be used throughout. That is my personal considered opinion. not the opinion of the government or the school I work for. Very, very personal, because abstinence is the key thing. And we talk of being faithful to one partner, because if one is not married and they're faithful to one partner for 3 months, and in 6 months that relationship is not working, and then they're getting into another relationship after another 3 or 6 months, and they're becoming faithful to that partner again, what are we talking about? And so I think the use of condoms is very key, but the use of condoms is only useful and beneficial when it is used, when condoms are used consistently and correctly all the time. That is when they are useful. Still on primary prevention of HIV, we have other strategies besides the ABC of safe sex. So we have the HTC services, that is the HIV testing and counseling, but of course we cancel first. This is just the naming of the strategy, HTC services. These are the testing and counseling services. And then of course we also have the promotion of VVMC, that is voluntary medical male circumcision. This was endorsed by the World Health Organization in 2007, together with the joint United Nations program on HIV and AIDS. And this was after it was found to be associated with an approximately 60% reduction in the risk of female to male transmission of HIV. So this is a good thing that we can advocate for, particularly in our adult male population that is uncircumcised. And of course, safe blood transfusion practices. All blood that is transfused must be screened for all other diseases, infections, or microorganisms, including the HIV virus. And then we have infection prevention and control at the workplace. Further still, we want to focus on the most at-risk populations, and here we are referring to women and girls, we are referring to children and the young, we are referring to the gay, the lesbians, the bisexuals, the transgenders, the young people we've already mentioned, especially the adolescents ages and all that, and also people who use injecting drugs. These are people who need to be supported so that they don't acquire this infection. Men having sex with men, yeah. And then of course we need to address gender-based violence and female genital mutilation. Intimate partner violence is highly associated with the power, power differences and things like that, and a lot of HIV transmission because of lack of ability to negotiate for safe sex. And of course we must always engage the community if we are to succeed. The prong number 2 was talking about prevention of unintended pregnancies in women who are already HIV infected. So here we are talking about preconception care measures, which include providing contraception, because without contraception naturally, and if people are going to have unprotected sex, one of the outcomes for unprotected sex without contraception is pregnancy. Okay, and then we also, part of the preconception care is knowing one's HIV status, and therefore, because that is very enabling, because then one is able to make informed choices. And then we also have partner involvement, they are partners because they don't live in a void. Then we are talking about emphasis on excuse me, good nutrition and provision of comprehensive post-rape care services. Yeah, so besides the preconception care measures, we also have lifestyle and behavior change. So here we are talking about strategies that help individuals to change their behavior, and with the aim of increasing the chances of a healthy lifestyle and also decreasing the risk of lifestyle related diseases. And then remember, I think STIs has come up so many times in this lecture, and so we want to make sure that these women who are already HIV infected, besides accessing preconceptual care besides being educated on lifestyle and behaviors that do not jeopardize their health, we also want to make sure that they are not getting STIs, and if they get them, then they are correctly and adequately managed. And of course, ART. Women who are HIV infected should really be on ART. Because ART has been found to reduce the viral load. Low viral loads are associated with lower risks of transmission, and so it is highly advised that any woman who is HIV infected should always discuss their options with the healthcare provider so that they can make informed choices, and things don't just happen on them like that, and that tends to give optimal outcomes, very good outcomes. The third prong was on strategies to prevent HIV in pregnant women. So here we are looking at the quality of antenatal care. We are looking at provision of routine HIV testing. We are looking at safe delivery practices. We are looking at ART, lifelong ART, and prophylaxis. We are looking at infant feeding and counseling, and we are also looking at long-term care of the baby and the mother. So, with reference to quality of antenatal care, we are emphasizing on provision of micronutrient supplementation. We are talking about screening and treatment of STIs as part of the antenatal care, and we are looking at treatment of intermittent infections, including malaria. When it comes to routine testing of HIV and counseling, this should be offered to all women, like we said, and it's an opt-out kind of scenario. And remember, it is not just HIV. Remember the triple elimination strategy, and so the testing should include screening for syphilis as well as for hepatitis B infection. When it comes to delivery, I think we mentioned a little bit about delivery previously on this lecture, and so we want to avoid as much as possible invasive procedures, including premature rupture of membranes, including episiotomies, and where possible we can also arrange for elective cesarean section. It has proven to be of benefit. Remember, we said that all women who are pregnant and they are HIV infected should be on lifelong treatment. Now, when you see the word prophylaxis there, it means that, we have women who may be otherwise HIV negative, but something happens and they get exposed. And so if they get exposed, then they can benefit from PEP. Okay, so that is where prophylaxis comes in. And then, of course, we're talking about infant feeding. Remember, the breastfeeding, exclusive breastfeeding, so long as the mother is on lifelong ART and the infant is able to receive a prophylaxis. Again, mothers need to be counseled so that they can be guided so that they can make informed choices. And then, of course, provision of long-term care for the mother, the baby, and the entire family. Last but not least, we're talking of prong 4. This is the use of ART for HIV positive pregnant women and infant prophylaxis. And so really the goal of ART is firstly to restore and maintain maternal immunity. So you want to restore the mother's immunity and you want to maintain it, okay, at optimal levels. And then it is also to prevent transmission of the virus by virtue or by way of suppressing the virus. Now, in order to achieve this goal, the mother must take effective ART in order to achieve adequate and optimal viral suppression. This means that the mother will be on lifelong ART. and this is with reference to pregnant mothers as well as those who are breastfeeding and they have HIV. And therefore, ART should be started as soon as possible. There is no point of waiting. And the first line ART regime for pregnant and breastfeeding women is a regime involving 3 drugs. We have tenofovir, then we have the lamivudine, and we have the dolutegravir. These drugs, these names tend to fill my mouth, so you will excuse me if I do not pronounce them the way you expected to hear. Now, to achieve this goal of viral suppression, which then is directly related to reduced risk of transmission, restoring the mother's health and maintaining it, then the mother must take effective ART to achieve the viral suppression, okay? I provided this slide so that perhaps you can just take time, pause a little, and just see the abbreviations for the various antiretroviral drugs. In my practice and in my learning as a student, these were some of the most difficult names that I ever encountered when learning pharmacology. So you will be excused, and everybody would be excused in the beginning for not catching them or not pronouncing them properly, not knowing which abbreviation goes for which kind of medication. But with time, it is possible. You just, with time, as you continue reading, as you continue participating in the management of these patients, then you get to understand and master the naming of the drugs. So let us look at the ART for HIV positive pregnant women and their infants. So for women who are newly initiated, we've already seen they are to be put on tenofovir, lamivudine, and dolutegravir. Now, here we have, once the mother has been initiated on ART, you need to do some follow-ups in order to know how you're doing, and if there are any other interventions that you need to take. So you need to take obtain a viral load 3 months after the patient has been started on the ART. After that, then you do viral loads every 6 months until when they will stop breastfeeding their baby. So it is the first 3 months and then every 6 months until complete cessation of breastfeeding. So HIV positive women who are already on ART at the time of confirming the pregnancy or who are already breastfeeding, what do you do with them? So you again obtain a viral load. This is irrespective of when last it was taken. It could have been taken 3 weeks ago, but you still take it because you see now you have just, discovered. So so you do a viral load irrespective of when prior viral load was done, and then every 6 months until complete cessation of pregnancy. So we are saying that for mothers whom you have just diagnosed and they are not yet, they haven't delivered, the first 3 months after treatment, you put them, or you check their viral load, and then you do so every 6 months until complete cessation of breastfeeding. But they're the ones who come in and they're already pregnant, they're already breastfeeding, so you must obtain, and they're HIV positive, so you must obtain the viral load. It doesn't matter when last the viral load was taken, and then you will continue every 6 months until complete cessation of breastfeeding. Okay. Yeah. So when you're doing this serial or periodic viral load testing, so you must be making certain decisions. So you're looking at the values. Now, there are those pointers that will show you that the patient is doing well, they're responding well to treatment, and there are those that will show you that nothing much is being achieved, and there are those that will show you that perhaps the patient is getting worse. Okay, so you need to be checking that every time you're doing the serial viral loads and then making new decisions. So If you do a viral load at any time and you find that it is more than 200 copies, then it means that patient is not suppressed. The viral load has not been suppressed. Okay? So what happens if that happens? You need to assess. You need to find out what is the reason that we are not achieving adequate viral suppression. And you know, within 6 months, really, you should have adequate, good, very good viral suppression. So you need to find out what is the reason that this mother is not achieving adequate viral suppression. Could it be that they are not adhering well to the treatment? Before you make the decision that they are not responding to the regime that you've given them. So what do? You have to address the possible reasons and then intensify the adherence, counseling, and support. And then you repeat the viral load at 3 months. Okay? And then you see what happens. Okay, then you'll make new decisions. Now, if you do a viral load and you find that the viral load is the viral copies are less than 200 per ml, then that's a patient who is doing well. They are well suppressed. And so what you do is just to continue with routine monitoring and continue with the ART regime. Now, there are those patients who will have very, very high viral loads, more than 1,000 copies per ml. If a patient has more than 1,000 copies per ml, then that is indicative of treatment failure. And now, in the case of treatment failure, you do not start looking for why and all that, but you just now have to think and say which other alternative regime can you be putting this patient on. And then we have those patients whose viral load will be between 200 and 999 copies per ml. This is referred to as low-level viremia. So what do? You reassess again, just like for the ones of 200 copies. Adherence, could there be a challenge with adherence, or what are the other challenges the patient is having? And then you try to address those. But in this case, you do not send them home and call them back after 3 months for review, but you need to consult the regional or national TWG for HIV and AIDS. Let us now look at the infant who is exposed. So we are referring to infants born of HIV infected mothers. Now, remember, exposure is determined by a positive antibody test, but then for these infants, you need to do a DNA PCR. We prefer PCR because then it picks on the antigenic material. So the guideline is that you do a DNA PCR within 6 weeks of age, or the first time you meet them after 6 weeks. So it is 6 weeks or whatever age thereafter. If the DNA PCR is negative, remember this is an exposed child. The antibody test is positive, so this is an exposed infant. So you're doing a DNA PCR at 6 weeks. It is negative. Then you repeat it at 6 months, and then 6 months later. That is when the child is 12 months old. In the meantime, they are supposed to be on infant ARV prophylaxis. What is the prophylaxis? We give them zidovudine and nevirapine for a period of 6 weeks. And after the 6 weeks, we drop the zidovudine and we continue with the nevirapine, and we add cotrimoxazole until 6 weeks after cessation of breastfeeding. So this baby will be on prophylaxis until 6 weeks after they have completed breastfeeding. However, if infant prophylaxis can be discontinued after a minimum of 12 weeks, that is 3 months, on nevirapine if the child is not breastfeeding. So this means that this is an exposed infant. You have established exposure, you've done a DNA PCR, it's negative, and so you start them on infant ARV prophylaxis. But these are infants who are not exposed to breast milk. so they are not breastfeeding. So what you do, you'll give them the zidovudine and nevirapine for 6 weeks, and then after 6 weeks you drop the zidovudine, continue with nevirapine and cotrimoxazole, and then give them for a minimum of 3 months, and then you can stop if they're not breastfeeding. But if they are, they will continue on that prophylaxis until 6 weeks after the last day they breastfeed. So this prophylaxis for infants will usually apply to all infants, irrespective of their age at which you identify their exposure. Okay, so remember we said anytime we are integrating these services into the antenatal MCH services, neonatal services, child and adolescent services. So at whatever point where you catch them, the infants, then you must put them on this prophylaxis. The dry blood sample or whole blood for PCR at 6 weeks or first contact, that's what you do. And then I'm going to refer to you to the early infant diagnosis algorithm, which you will find on page 2-9 of the Kenya ARV guidelines of 2022. You refer to figure 2.1. It has the algorithm. Now, we have the birth testing, which may be conducted in sites where point of care has been implemented and when medically indicated. Remember, birth testing cannot just be done anywhere, and we shall look at that briefly. I think we looked at this during testing. I think so. I don't know if it's part of this lecture, but I think I have mentioned it before. So again, yeah, it was covered in the testing lecture. And so I'm going to refer you again to the algorithm of figure point 2.2 on page 2-11 of the Kenya ARV guidelines of 2022. So remember, birth testing is not done everywhere. These are points I need you to note, that a contraindication or inability to tolerate nevirapine or zidovudine, if that is existing, then you need to give a drug that is tolerated. If the infant on zidovudine prophylaxis, give up to a maximum of 12 weeks or until maternal viral load is suppressed. If neither AZT nor nevirapine are tolerated, then lamivudine is an option if it is available. All infants should be exclusively breastfed for the first 6 months of life, with timely introduction of appropriate complementary foods after 6 months and continued breastfeeding up to 24 months or beyond. I tell you, when we arrived at this point, I was all smiles, because now I knew that all our babies will be exclusively breastfed, irrespective of the HIV status of their mothers. So I'm sharing these dosages as extracted from our guidelines, Kenya guidelines. So we start with the nevirapine and the zidovudine. And I'm looking at this and I'm thinking, how can I make it easy for you to remember? So look at, we start with the first column of age and weight. So here we have, we are looking at the age, birth to 6 weeks, and then we have those who are more than 6 weeks up to 12 weeks on this slide. So birth to 6 weeks, again, we want to break them up into depending on the birth weight. So we have 3 categories. For those babies who are less than 6 weeks, we have 3 categories. The birth weight of less than 2 kilos and birth weight of more than or equal to 2.5. So 2.5 is the beginning of the normal birth weight. So more than or equal to 2, so normal birth weight. And then we have less than 2 kilos. So that is, 1.999. And then we have those who are between 2 kilos and 2.5 kilos. All right. So let's have those two first. Less than 6 weeks, we will consider the birth weight. Above 6 weeks, we will not consider the weight. Okay. Look at nevirapine. Nevirapine is an OD dosing all the time. Zidovudine is a BD dosing all the time. All right. Look at nevirapine. Nevirapine will give, if they're less than 2 kilos birth weight, 2 milligrams per kg OD dosing. So for zidovudine, you double that at the same age, the same weight. So you give 4 milligrams per kg per dose twice daily. Then when it comes to those who are above 2 kilos, between, above 2 kilos but below the normal birth weight and then normal birth weight onwards. So for nevirapine, you'll give 10 milligrams and zidovudine the same, 10 milligrams. Although nevirapine is OD, zidovudine is BD. And again, for those who have normal birth weight going forward, it's the same dosage for both. So the differences are only in those who are less than 2 kilos for birth weight, and then you double the dose when it comes to zidovudine. Now, when they are above 6 weeks up to 3 months of age, irrespective of the weight, they'll get 20 milligrams of nevirapine and 60 milligrams of zidovudine. OD for nevirapine, BD for zidovudine. Now, so let's look at if the child presents to the facility late and has to be on zidovudine and nevirapine beyond 12 weeks of age, what do you do? So 12, remember the previous slide, we went up to 12 weeks, and these are children we caught probably at birth or before birth. So when they were being born, we knew exactly what we were going to do. But then these ones are coming in a little bit later. So 12 weeks to 6 months, and it is nevirapine. You remember nevirapine is OD always. So you give them 25 milligrams once a day. So three months, from 3 to 6, those are 3 months, and then 7, 8, 9, another 3 months, 10, 11, 12, another 3 months, and then above 1 year. So you do the 3-month intervals, then 25, 30, and 40 milligrams. I think that becomes easy to remember. And if they are more than 1 year and they are coming in for the first time, then you see this infant prophylaxis becomes a little bit of a challenge. And so in this case, you may need to consult the regional or national HIV clinic, clinical TWG, and the numbers are here. I've provided them for you, and it's a hotline, toll free, and also an email. What about a child presenting to the facility? Now we are looking at the zidovudine doses. The previous slide was the nevirapine. So here, remember for the nevirapine, we were using the age in months. So 12 weeks, that is 3 months to 6, then 7 to 9, then 9 to 12, and beyond 12. Here we are using kilos. Again, looks like 3, 3, and then 4. So 3 to 6, 6 to 9, 0.9, then 10 to 13.9, and then 14 to 19.9. So you give 6, 9, 12, and 15 meals BD. Again, these are things that you get to master as you continue rotating in the CCC clinics and participating. So remember we talked of the dual elimination, the triple, not dual, rather dual is the testing for HIV and syphilis. And then of course we have hepatitis B, but the strategy is for triple elimination. So let's talk about syphilis, elimination for pregnant and breastfeeding women, as well as their infants and their treatment. So during the antenatal visit, a mother who is not aware of the HIV status must have or should have the dual HIV syphilis test during the first trimester. Remember, you offer them the test, they agree, you do the test, it's an opt-in. Rarely do they say no. Okay, now if remember we said if the initial test is negative in the first trimester, you repeat the test in the third trimester. If it is negative, you're happy. And remember, even at delivery, when they come in during labor, you still do the test because you don't know, okay, for the mother. And then we have the positive. If the syphilis positive test is positive rather, at any point during pregnancy and breastfeeding, then you have to treat them using penicillin. And here we usually give penicillin G 2.4 mega units IM stat, or if they're allergic or hypersensitive to penicillin, then you give ceftriaxone. Now, the difference between penicillin G and ceftriaxone is that penicillin G, you give it as a start dose, and it's usually a high dose of penicillin, but in the case of ceftriaxone, you give a daily dose of 1 gram IM, and you give it for at least 8 days, preferably 10 days. And then remember, just like with any other STI, you need to contact trace so that you can be able to treat all the other sexual contacts, because they are likely to have also contracted the infection. All right. Now, for the infant who is exposed to syphilis, again, you treat with crystalline penicillin. Remember, with crystalline penicillin, the dose is usually the same, except when they are less than 1 week old, it is given twice daily, and then when they are more than 1 week old, you would give them thrice daily, and the duration will be 10 days. When it comes to hepatitis B, again, remember you're offering this test during pregnancy. It's not only just B, but also C. So for patients with a positive test, you need to offer them appropriate treatment with ARVs. And it has been found that ARVs with tenofovir, lamivudine, containing regimes, they tend to help. If a mother is already on ARVs and they contain these regimes, then they are also protected from hepatitis. But if they are not, then you may consider that, or I'm going to refer to you to the national guidelines on viral hepatitis management. There you'll find the details, because it's an entire topic of its own, okay? So we won't go into the heavy details of the same. So the treatment also acts as prophylaxis for hepatitis B. I've already said that. Now, women without evidence of hepatitis B infection, that means their test is negative, then they should be offered the vaccine. But those who are positive, the HIV positive infants without evidence of infection, again, it's preferred that they get the vaccine at birth for hepatitis B. Now, infants born of mothers who test positive or for hepatitis B surface antigen, they need to be treated. So these infants will get both the immunoglobulin and the vaccine. And it has been found, actually, I know the next question you would want to ask is that how can you give a vaccine and the immunoglobulin at the same time? Won't the immunoglobulin neutralize the vaccine before, it has been able to stimulate an immune response? However, studies have shown that response to hepatitis B vaccine is not weakened by the concurrent administration of the hepatitis B immunoglobulins, and that this combination of both the vaccine and the immunoglobulin dosages will usually produce immediate and sustained high levels of protective antibodies to the hepatitis B surface antigen. So it is safe to do that, because it is not just something that is being said, but it is something that has been tested scientifically, and studies have shown that there is no counteraction of the treatment expectations. With those very many remarks, it's been a fairly long lecture. We both need to grab a cup of tea, maybe grab a cookie, grab a cup of coffee, and then come back for part 2 and part 3. I want to say thank you for your attention, and it's been interesting being around, and I look forward to seeing you for part 2 and part 3 of this lesson on prevention of HIV in children. Thank you and goodbye.